Hey everybody, what's going on? Gestalt Education back for another year. We're going to start this year off right with letting you save some money. So two of our favorite people are the Core 360 belt and Human Locomotion, which is Dr. Thomas Schaud. So don't forget, if you use the code Gestalt for the Core 360 belt, you get $5 off all belts except for the Ohm Track sensors. So Brett, what are some of the Schaud's favorite, some of your favorite Schaud gadgets?
Well, I mean, he's got a trunk full of gadgets, but I think my favorite one definitely would be we use the Toe Pro quite a bit. The Toe Pro, and then I think the Varus and Valgus Post have really given people like a nice option if they're not want to take that leap into like a customized orthotic to kind of a good option for the patient, but also to let them kind of like, bring the power back to the clinician to kind of decide where to post it. And so I think those are the two probably ones of Tom's stuff that I love. And of course, I can't get enough of his Human Locomotion. I mean, the book is still to this day pure insanity. So
beautiful. Yeah. Don't forget to use the code Gestalt on both those, the Core 360 belt and then also Human Locomotion. Links are in all of our podcasts. And we hope you guys like today's episode. All right, everyone, welcome to another episode of the Gestalt Education Show. Today we are back for round two with our guest today, Brett. So Dr. Dave King, so you did such an amazing job last year at this time talking to us at the C course, DNS C course. And then last year you talked about femoral osteotopic impingement, labral pathology, kind of all those the normal things that you see in the operating room. But then this year, what was awesome, you kind of flipped the script on us a little bit. So you kind of talked about your failures and not necessarily even your failures, but the patients that are difficult. People that you may have trouble helping or that just complicate the case, period. And so I thought you did a great job. But do you want to just kind of run through that list for us a little bit on the patients that are difficult or kind of those presentations that suck to walk into your office?
Yes. Well, first of all, thanks for having me on again. First time was a blast, and I'm sure this is going to be even better. I am drinking some lovely champagne.
Yep. Cheers.
Glorious. We're watching the France-Poland World Cup, and wow, what a start to this Sunday.
That's right.
It's only going downhill from here.
Yeah.
No, anyways, so yeah, I think the official title was the Female Athletic Hip, What Keeps Me Awake at Night.
Yeah.
And really it is. So now 16 years into practice, and you go from sort of having this, I don't like God complex for this, but you have a very optimistic approach and feel that you're really going to help everybody. And there comes a point in your career where you have to stop and say, all right, where are my failures? And whether that's, a complete failure or that's somebody that just didn't have as good an outcome as you'd hope to do, it's important. It's important to stop and look at that stuff. So I did a big data evaluation recently looking at those in my practice, and found the list, just kind of break it down. The people that struggle are my female athletes in between 13 and 16 years of age. Specific sports were soccer and then dance, cheer. I'd throw gymnastics in there, but there just aren't a lot of people in gymnastics right now. Mm-hmm. That's a high concern for not doing really well. Patients that play year-round competition. We talked about
club.
Club versus their high school sport. That was kind of a big one for us. And then was there another list on the list? I can't remember if there was another one there.
That's a pretty good start.
Yeah, it was a good start. And we were kind of diving into that in terms of what it is about it. And one of the things we got into was the year-round. I brought up the example of gymnastics, right? So there are obviously the crazy parents who are doing, I think last year I even brought up baseball, Little League baseball and dance, that people were just a little bit too psychotic about their kid, little Jimmy being the best in the world. But there's a lot of well-intentioned parents who are trying to do what's right for their kids. But a sport like gymnastics, asking a gymnast who does complex movements that are, it's timing, it's strength, it's power, it's all of it, and say, hey, let's take 3 weeks or 4 weeks to rest. They might as well be done for the season.
Yeah.
What it's going to take them to get back. I think I've heard at least one of my patients describe, every day I'm out is about a week of return to get back. That was a pretty good gymnast of mine.
So that almost adds another complication in because they may be pushing harder to return.
Yeah, correct. They're pushing harder, but and they would like to rest, but it means it's just difficult, So that's hard. And then the other is the big one that I get really outspoken about and aggressive is this tournament play, especially in soccer. I mean, the idea that we're sitting here watching the World Cup, I mean, it couldn't be any more apropos, but that you're now asking somebody to run. I mean, how many miles do these kids run on it? 5 games in a weekend? And it's like, I wonder why you're having hip pain. I mean, I think anybody without a hip issue potentially could feel their hips on that. So it's just really difficult, that tournament play. Whereas in high school sports and collegiate or even this professional level, you're training appropriately. You have your training days, but then you're actually really only in that heavy competition maybe twice a week, maybe at the worst 3 times a week. So.
And you noticed a significant difference you were talking about from when they just play high school soccer, which St. Louis has great high school soccer, female soccer. So versus club. So is that message being well received? Are people listening to you or mixed bag?
So the poster. So first of all, I'm sure I preached on this last time I was here about the preoperative counseling. Really sitting down with the kid and the parents, but much more the kids than the parents, and really educating them on the whole process. But the failure rates, this is even before I did the most recent data dump, was 50% of my female soccer players in St. Louis got back to club play at a high level and were happy. So a lot of them got back, but they just said, this isn't where I want to be. I'm better than before surgery, but this just doesn't feel great. It's like, I'm not, I play on the weekend and then Monday and Tuesday, it's hard to sit through class. So anyways, but you have that conversation, but the success rate, the flip of that is that the success rate of those individuals who said, I'm going to take a pause on club, maybe take a year off, play my high school season. The success rates are huge. Yeah. They can get back and they're like, wow, by the way, this is really fun. I'm one of the best kids on the field. There's camaraderie. And it's not quite as intense in my hips.
Whoa, sports cannot be fun. Wait.
Yeah, no shit. God forbid we have a little bit of fun.
That's great.
Yeah.
It's true.
So the other thing we talked about, even in our world, dysplasia is very tricky for us to work with too, because a lot of times you might be dealing with other concomitant problems like maybe loose connective tissue, things like that. You talked a little bit about, and it's not your forte. You say you refer out for the surgery on dysplasia. But can you talk about what that clinical presentation looks like, how it's different from femoral acetabular impingement, the management of that? Yeah,
so I'll lump the two together in terms of dysplasia and then just what we call version-related issues.
Right.
So dysplasia, when I talk about dysplasia, or we do in our world, we're talking truly about the socket. Technically any malformation of the socket would be dysplasia, but when we talk about dysplasia, we're really talking about the socket doesn't form correctly. So you have less surface area, improper angles of the socket side so that you can't contain the femoral head as well. The other part of that is versions, which is when the femur comes up and splits to the femoral neck, you either have, a version, we'll call it upright or flat, and then we also have version in the frontal plane or the posterior plane. So anaversion would be the frontal plane, posterior would be retroversion. Mm-hmm. But they're difficult. So a lot of times with dysplasia, you have vague type symptoms, achy. It involves multiple areas of the hip joint. It's not the classic groin pain in the impingement position. Mm-hmm. It's sort of this nebulous pain, and it's tough to figure out exactly what that's coming from. A lot of times they have secondary soft tissue issues, so they're coming to your office and you're like, well, they leave here and they feel great, mm-hmm. right? Because you're managing those secondary soft tissue related issues, but then they try to get back into their activity or competition and they struggle again. Version is something that we're learning more about. Really, Brian Kelly had an awesome study with some other guys in 2015 looking at retroversion and the failures in hip arthroscopy, and there's been multiple studies since then. But from the clinical setting, really looking, and what we talked about today was looking at version, so seated 90 degree with the knee at 90 degrees and looking internal and external rotation and measuring the differences, as well as in Craig's test or laying prone and looking at it. If you see more than a 20-degree discrepancy between internal and external rotation, that's highly correlates with either increased version or decrease, so more anteversion or retroversion. And again, very subtle. The cam, what we talked about last time I was on, femoral acetabular impingement, cam impingement with a labral tear is a lot. My kids could diagnose that.
Yeah,
flexing up, internal rotate. It's a home run. I mean, it's really loss of Faber, all those other things. So that's pretty easy. The dysplasia and the versions are more difficult, but they are a huge component of why we have failures. Mm-hmm. It's because we're trying to push the limits. These athletes have given so much, they don't want to go through a bony corrective procedure. So we do everything we can on your end and my end to say, let's not operate, let's keep them going there. But these really influence. They also have a big influence on when they do get to the point and have an arthroscopic surgery, that they're at a high risk of having mediocre or less than ideal results.
Have you noticed, because it's kind of like the razor's edge, because if you have dysplasia, the blessing of the dysplastic hip is that you have a lot of range of motion, which can be beneficial for athletics. Whereas like you have retroversion, femoral acetabular impingement, you run out of hip motion, therefore it all gets funneled into the low back. Have you noticed that in a way it's kind of like a blessing and a curse, that a lot of high level athletes in rotational sports might be using a little bit of their dysplasia to kind of give them more range of motion potentially?
It's the New York School of Ballet. I mean, the number of dysplastic students that enter the New York School of Ballet, the premier in this country, I don't know if it's the world, but that's the majority of them have some form of dysplasia.
Right.
And, there's obviously a lot of talent and strength and everything else, but yeah, not having that acetabular coverage allows them to reach certain positions that the rest of us can't.
Because they can keep their spine neutral then,
absolutely.
Like instead of compromising.
Yeah, so their form is beautiful, right? Whereas, throw somebody with a normal hip and a little cam bump, let them try to make those gorgeous, ballet motions. There's no way. They can't do it. You just can't do it, Gymnastics is the same type of thing. Dance, cheer, all those things. So, yeah, it's huge. And then you're doing these high impact activities, and it's just like, it's a blessing and a curse, exactly how you said.
And you talked about the imaging too, is that CT scan is the gold standard as far as measuring those things and seeing version and dysplasia and stuff like that.
Yeah. So, simple x-rays are, key for FAI and dysplasia really, but MRI for looking for tears. But the CT scan really is the best thing to look for version studies. But, front line between chiropractics and athletic trainers and physical therapists, they're usually seeing these patients and touching them first, and they're the ones that can really screen them and see if you have, difference between internal and external rotation of 12, 15 degrees, the chances of you having something dramatic on your version studies is pretty low, Sure. So really the screening part of it we don't want to just go around CTing every kid out there, Sure. Unless you're doing a specific research project that's going to add to the medical literature in terms of evidence-based medicine, then okay, that's okay. But me in the private world, I don't want every kid coming in radiating that kid. But it helps. It helps having that. It also helps. It helps. I think the athlete. A lot of time it's confusion. I can't tell you how many athletes I've met, counseled, figured out. Yeah, you've got some increased anteversion. You've got a tiny bit of hypermobility. Maybe we can make some modifications to your workouts. And that athlete can then mentally get back and play.
Okay.
And now they're seeing you guys. They're seeing their chiro. They've got their trainer's got some things they got to do. They have to skip a Wednesday practice and do a core strengthening video instead of pounding on their hip. A lot of runners this way, cross country. But once they know, then they're able to process it all and figure out a game plan to keep themselves going and avoid the knife.
Right.
And that's, knowledge is power. What was that, G.I. Joe? Did I just quote G.I. Joe on your podcast?
That's the first time.
That's never going to happen again.
That's the first time.
That's a verse. You never forget your verse, as they say. Well, what about on a plain view x-ray for, if you're looking at acetabular coverage, there's crossover signs and things like that. Although it's not the gold standard, is there something to be learned from a AP X-ray of the hip or
Oh, absolutely.
Yeah, okay.
Absolutely. So what the problem is most people it's like if you look at a trauma center ER, they'll get CT scans of the head, neck, pelvis, the whole thing there, and they say no fractures, acute process, normal. Well, they're not. They're just looking for deadly shit, right? Stuff that's going to kill you overnight while you sit in the ICU. But there's a lot of subtleties on it. A lot of times, a non-hip specific, even orthopedic surgeon, they'll look at a basic AP pelvis and they will say, "Oh, it looks normal. There's no arthritis. I don't see anything." But there's so many subtleties. I mean, it's almost rare that if you have a guy like myself or Philippon, Kelly, all these other guys out there who do a lot of this stuff, there are very rarely are they perfectly normal X-rays. There's always some subtleties to it. So you can gain a lot of information just from a plain X-ray.
I think the one thing you said today that really surprised me when you were talking about your buddy, Dr. Kelly, is that in surgery for dysplasia, they actually change the version. They essentially break the hip. I don't know if that's the right term, but
they do an osteotomy. So it's a controlled cut, and then they actually rotate and change the version, which is super invasive, and there's no way that I can downplay that. I'm about to put my son through that at some point, but it solves the primary problem. I used to talk about it a long time ago, and I brought it up in the talk today when I used to give a lot of the talks when I was teaching about pincer and cam, and say, make sure that you are fixing the primary issue, meaning if the primary issue is a cam lesion on the femur, don't go shaving a bunch of the acetabulum or socket to try to make up for that. That's not a good idea. Conversely, don't do a massive divot in the femoral head neck junction if they really got pincer impingement. Go to where the problem is. So, I mean, nobody wants to talk about breaking a femur and turning a femur. It's just sort of from a baseline, parents look at you like you have two heads, Even I look at my patients and I was like, I can't believe I'm sending them to do this. I just feel terrible for them. But you got to fix the primary problem.
Yeah, we talked in FAI how, if we were trying to find the etiology or the cause of the problem. Last time we had you on, we were talking about early rotational sports where you're literally in range of motion, just butting your femur up against your acetabulum. You have Wolff's Law, Huter Volkmann, where you basically are laying down bone because you're, the cam thing. Now, on the dysplastic hip, do you feel like that's just purely genetic, or is there a way to get there? What's a pathway to get a dysplastic hip?
So, current consensus is it's congenital.
Okay.
And it's congenital, and the question is are there things that happen in life that allow it to correct itself? So for example, you get a dysplastic baby, and there are some bracing type things you can do to drive the femoral head into the socket that helps the socket, form correctly.
Sure.
So there's definitely things you can manipulate. The problem is figuring that out at the right time when they're that malleable as a baby to correct it. Most of the time in my world, without not being a pediatric ortho guy or being a pediatrician, it's all they're too far into the process to really make a big correction there. Sure.
And it's kind of like your car. You don't really go preventatively, except for an oil change, to see like, oh, how am I doing? I think the human body, we wait for things to kind of break down.
But it's a funny thing. I love to make one controversial statement, but
let's go, baby. Come on.
No, I mean,
so last time it was dancing.
Yeah. Well, it was dancing.
You canceled yourself on the
dancing. I have dancers. They all hate me. All the dance studios hate me now, but whatever. I can live with it. So I X-rayed I have 5 kids, and I X-ray them at different intervals, looking for dysplasia, looking for OCD lesions in the knee, looking for congenital stenosis, something in the cervical spine that might, lead them to be a paraplegic on the field. I mean, in public health, we always talk about public health. Why do we give vaccines the way we give vaccines? Well, it's because why do we stack them on top of each other? It's because how do you get the most number of people vaccinated appropriately? This is in public health. This is how you do it, right?
Yeah.
You could easily spread your kid out and say we're gonna do each one at this time, but then obviously
people won't follow up.
They won't follow up, and their kids don't want to do it, and it's all those reasons there. The other one is the other one I tell all the time is in med school there's three gals that I know keep in touch with someone who went into OBGYN, and all 3 of them had elective C-sections for all of their children.
Wow.
And it's like, we there's a public health kind of, this is how we tell the general population to do it, and then this is what we do ourselves. Yeah, this is what we actually do for ourselves. The reality is a lot of the hip-related issues, there are time points where you could make changes and help it. But, the body's amazing. Torsion, anteversion, femoral version, they're supposed, like we talked about today, all of those things they do naturally ebb and flow throughout your development. We've seen those patterns there. So it's not like we want to do anything crazy and intervene too early, but at the same time, there probably are those patients that we've missed the chance along the way to fix them. So
sure.
Yeah, with regenerative medicine, I know you're a proponent. How do you use regenerative medicine? Obviously in St. Louis, we have Blue Tail and other people that are doing the service. The things we hear are PRP, stem cell, prolotherapy. I mean, do you just send people to the people that are doing regenerative medicine and they make a decision on what they're going to do? Or do you have like an opinion on what's good, what's not good?
Yeah,
we'll talk about the hip, of course.
Yeah. So, I use it for all different parts, but I have I definitely send them if I sort of have a target issue. For example, 16-year-old ice hockey goalie, massive cam lesion. He's hammering his hip into traditional butterfly position, develops a large labral tear and a 30% of his acetabular reticular cartilage. He's got a chondral flap. That's a mess, right? So I won't, in that situation, I won't literally cut out the damaged cartilage, but I also know that it doesn't have a great chance of healing. It's very hard to do microfracture in the hip. It's a tough problem, right? So I'll fix the labrum. I'll remove the cam lesion. Traditionally, I'll use this. Arthrex has this thing called a power pick, which is this mini microfracture device that can try to help create some channels in the acetabulum, and then I will send that to the Blue Tail guys to be fed stem cells post-surgical, right? Wow. Just the concept being is how we got a tough problem. Mechanically I've fixed what I can. How do we try to throw the kitchen sink at it to get that thing to stabilize and potentially do well? So that's a specific application.
So you're using regenerative medicine after your surgery, kind of. Oh wow!
Yeah. And is your goal?
I used to do actually. I would actually do an injection at the time of surgery, but in my opinion, you're getting enough blood and potentially stem cells through the little mini microfracture, and there's chaos with fluid, and I'm injecting numbing agent. I just feel like you're wasting the stem cells at that immediate time, that you're generating enough, and the idea would be to feed it. And occasionally, based on the size of the lesion, sometimes they'll feed it with PRPs. A lot of times, if you're in a joint, it's traditionally, by no means a biologics expert by any means, but stem cells tend to thrive in oxygen poor environments, which would be joints versus the lateral elbow, where you have a oxygen rich environment. They do better with platelet rich plasma, that type of stuff. So we'll typically send for stem cells for cartilage type issues, but iliopsoas tendonitis, thin anterior capsules in females who have maybe a slight bit of hypermobility. I think regenerative in the capsular tissues to get them to scar and tighten up. That's a great application for it.
And that's your goal with it, would be the scarring aspect of it. Is there any anti-inflammatory component to that as well?
Oh yeah, absolutely. Yeah. I mean, they have, PRP itself is actually stimulating inflammation just in a controlled environment. Stem cells into a joint tends to create a more neutral environment, if you will. But yeah, and I don't know. We'll have to see where it all goes. But we're trying to take the data of, hey, these patients don't do particularly well. How do we try to improve those outcomes? I mean, that's our goal.
I think you made a really good point today about exclusionary criteria for you with the injection under ultrasound. Like, you kind of definitively know who's going to be. You're setting yourself up for success by, if they pop or are positive or negative on that. Can you speak on, over the years, how you've developed this little protocol that you've bought into? And
for sure. So we call it the final step before you're indicated for surgery, which is the diagnostic injection. And it's actually interesting. So there are peer-reviewed studies out there that show that the response to the injection before hip arthroscopy can vary, but still have successful outcomes. Okay. I say bullshit. Definitively say bullshit on that one.
Yeah.
So I've looked at my first 1,000 patients. We collected all this prospective data and looked at, post-surgical data and everything. And, the patients that did not respond to a preoperative diagnostic injection did not dramatically improve with surgery. That's my practice. It has been for 16 years, 4,000 to 5,000 hip arthroscopies. I mean, that's the fact. So the concept of the injection is this. If your labral tear is the source of your pain, we're going to temporarily shut that off and determine if your pain goes away. So patient comes in, they've got their labral tear, FAI, they've failed all the normal criteria and everything, and they're indicated for surgery. We will say, okay, how's your day going? Is this a good day, bad day, mediocre day for your pain? And if it's a bad day and they're doing very poorly, we'll do it right then. If not, we'll send them away and we'll say, go get your hip inflamed and pissed off and then come back and see us. And then their ultrasound in the office, we'll do an injection with lidocaine and marcaine, 2 numbing agents. Lidocaine acts very quickly. Marcaine takes a little longer, but it lasts longer. And we are looking for a definitive resolution of their normal daily pain that they have that's limiting them to determine if fixing the labrum's actually going to fix their problem. And you'll see a variety of things. People that have hip pain, some back pain, a little bit of thigh pain, all this kind of stuff. You'll get the absolute home run injection. Wow, that's amazing. Tear of joy. Like if I could just feel like this would be awesome. Yeah. You're like, great, done. We're good. We're indicated.
See you Wednesday.
You'll get the other one where they have, these tend to be my kind of more my age patients. I'm 47 now, more my weekend warriors, and they'll be like, I got a back and this and other. And you'll do the injection with like, oh, my hip, that feels great. My groin pain's gone. My motion's better. And they're like, my back didn't really take my back pain away at all, but this all feels amazing. And a lot of those times you go, okay, great. We're going to fix that pain that went away with this surgery. Then we're going to see how much that was affecting your back. We may or may not fix your back pain. Yeah. We may or may not fix your back pain, but now you get a snapshot of what will go away, what might or might not.
Okay, so someone
and you might get somebody who it's a labral tear, it's FAI, it looks everything, and you do the injection and they get no response. You got to go deep, brother. You got to go figure out. Okay, I'm not convinced. I got to go figure out what this is.
Well, that's my next question. So if they don't get that positive outcome from the injection, then are you looking like more kinetic chain, like this is potentially coming from the low back, or could the hip still be the problem? It's just not the labrum, or
exactly. Yes. So both of those are perfect. So yes, it can be, referred from the back is usually pretty obvious to us based on dermatomes and other kind of provocative things. We do see a lot of athletic pubalgia or sports hernia type stuff. That can cross over pretty quickly. Mm-hmm. Or yes, you can have FAI that is, triggering iliopsoas tendinosis or issues with the reflective head of the rectus or some other soft tissue structure that can just kinetically be affected, kinetic chain. But you're like, okay, but it's not the labrum. Like just the answer, maybe the answer is fixing the cam impingement. But again, my outcomes are terrible on those patients that don't see a response from that.
And if you're in blue collar America and we want to use Dave King, how much does it cost for somebody to send a patient to you for this ultrasound injection? Like, is this like $2,000? Is this $500 or what's
Well, I mean, it's if you haven't, it's routinely covered under insurance, but no, I mean, lidocaine and marcaine, lidocaine's hard to find right now because of supply chain, but it's cheap.
Okay.
A couple $100 max.
Yeah. Right. So that's a no-brainer.
And it's the information is so, it's amazing. And we just have I'll get a lot of patients sent, tons of patients from back specialists, including back surgeons in town, spine surgeons around St. Louis and the metro area, even some of the smaller areas, just to that. They say, hey, can you rule the hip out for me? I'm dealing with this back issue. I've got multiple discs. I've got stuff. We're doing selective nerve roots. We're doing epidurals. We're doing all these different kind of things. And I was just trying to, but there's so much crossover with the hip. I can't quite figure out if this is the hip. And so they will literally get sent to us just to rule out the hip, and they'll come in and it's for the diagnostic injection. So, but we'll look at their hip, x-ray, examine them, kind of put our 2 cents in, and we'll do that injection. And, we've had patients who've had 3-level lumbar fusions and, 8 years of treatments, and
You don't want.
holy F.
Yeah,
it was my hip the whole time.
Watch what you tell them.
Oh, yeah, you almost feel bad saying that. Like,
Yeah.
shit.
Yeah.
It wasn't.
Well,
It wasn't
but
a complete waste.
but I
but
Well, but I think now, a lot of the guys, there are plenty of good, awesome spine surgeons who now have figured this out, and they're like, wait, time out. I want to do this first.
yeah,
No,
that's fair.
last thing I want to do is another failed back surgery like that.
I know, and I mean,
They don't want to manage that. Nobody wants to manage that. And there's no dollar in the world that's worth. At least if you're a reasonable human and you're an ethical doctor, can you imagine giving people a failed back when you know it was something else? You just you wouldn't do it.
That's tough.
What's the weirdest?
So they never knew. They didn't know. They were, a lot of them are just they think they're doing the right thing. Yeah, this sort of fits. Yeah, they sort of got better with this epidural injection. Sometimes they're not that definitive. The hip, though, injection, that's definitive.
right.
Either it takes it away or it doesn't take it away.
What is the weirdest, like, sclerotogenous referral pattern you've seen that wasn't so straightforward to where, like, you did your procedure and, I mean, because the debate rages on. I mean, depending on who you talk to, does the hip refer below the knee? I don't see that very often, but I mean, you hear people talk about it. So, like, have you had any crazy cases where, like, you fixed their hip and you're like, wow, that fixed?
Well, so yes, I mean we've had it sort of when you Monday morning quarterbacked it sort of makes sense. It was somebody that had clearly had groin hip related issues, limited Faber motion, like they were locked in, big cam lesion, labral tear, no arthritis, did their injection. A lot of the pain went away, but they were having truly radicular down to the leg, down to the foot, numbness there. They had a disc at the area, but they weren't really responding there, but they had so much, and it was like both of them were driving them nuts. Actually, at the time, the hip was keeping them from sleeping. Okay. So they were probably in their early 40s. Fixed the hip, rehab the hell out of them, and then really put them with somebody who really understood hip and back, and then they got they had a good chiro as well, and who just was kind of watching this very, very closely along, and sure enough, all the symptoms resolved, and really they did a follow-up MRI later, and the disc had disc had retracted and healed itself, if you will.
Right.
It wasn't big bone spurs and stuff, but that was one that I really didn't think was going to do much. But when the stress came off the back, it just let it, it let everybody else do their work and help them heal themselves. Sure. Plus I put them through, I put them outrageous core strengthening programs.
Smart.
I tell everybody you're going to fit. You'll leave with stronger core than you started with, unless they're professional hockey players. Those guys.
Yeah, what a good message. Yourself, when we had Dr. Andrews on, what can you learn from your failures? I mean, that was basically how you started your lecture today. Mm-hmm. Yeah, let's talk about that, because I think, a lot of people, especially early on in your career, all you want to do is kind of grandstand your great cases, what do you learn from your failures? How do those keep you up at night? How does that make you better?
Well, it makes you kind of go back to the basics. We were talking right before we started here, that when this meeting was coming up and you're like, hey, can you come out again? It was sort of work administrative stuff, life, family. And
you gave me hockey excuse.
My brain, and I didn't know at the time the hockey schedule, but my brain was just sort of in but then I was like, you know what? I need to do this, and I want to do this. And then you sort of get back to the basics. So number one, we're in this for patient care. If you didn't become a doctor and a surgeon and do this to help make people better, then there's something wrong with you, So it kind of makes you reset, and then it makes you a scientist again, right? So one of the examples, that was the last thing on the list of my failures, and I didn't say it was mental health, anxiety issues. Yeah. That was a big key that we found for that, and it says, boy, I'm the farthest thing from a specialist in that world. But boy, it made you start thinking about it. Like, is that something that says don't operate on that person? No, because part of their mental health problems and anxiety might be from their pain.
Yeah, their neurosis is.
Yeah, so it's like a catch-22. But you're like, okay, I need to find people to help me work on this. What do I do? And I've found some ways just myself on how to encourage those patients, and I approach them differently in their post-operative settings, more of an encouraging person versus I can be a real hard ass, post-surgical if I don't think you're doing your stretching exercises for your shoulder, or or if somebody's doing too much too early, so like if that patient is doing a lot, they need to, right? So they're doing more stuff, they're more active on their feet, they're going out with friends, they're doing things there. A lot of times I might want to chastise somebody and tell them to chill out, and that person, you're like, okay, I gotta have kid gloves on this. I gotta talk about how I want you to be active, but be smart about it. So it makes you kind of think about things more. We're still looking at some of these other biologics. It's very easy for the orthopedic surgeon. We've looked at incorporating that into our own practice, just as another one site practice there. And you realize that you don't have time to give it what it needs. Whereas like all my boys and girls at Blue Tail Medical are just so damn good, and they have such a scientific approach to it that I'd rather just collaborate.
Farm that out.
Yeah. But it makes you think.
Yeah.
Makes you think, who needs that? Who needs that? What am I missing? The version stuff. Thankfully, it's a small world. The hip arthroscopy community is really small, even internationally. But it kind of makes us all think and talk to each other. Hey, I just looked at my failures. Here's what I'm seeing.
Right.
Yeah.
And when we saw, like when Brian Kelly and his guys showed that retroversion is a big killer, but that very excessive anteversion can also be a bit of a problem there. And just so. It's fun, and it keeps you kind of humble and interested.
Yeah, right.
If everything was a home run,
it'd be so damn boring, wouldn't
get
it?
a little boring.
Yeah,
he knows his story. My first professional athlete, he ends up having femoral tabular impingement, so he ends up going to spring training, and so I mean, I've seen him 6 times. He's referred to me because at the time I'm a big ART person, things like that. I don't help this guy one bit. He goes to spring training, and maybe he's doing a little bit better. And then I'm just kind of, young, dumb clinician. I'm like, yeah, how's everything going in spring training? He's like, actually, I'm in Vail right now. I'm about to go under surgery. So, and femoral tabular impingement, at least in our world, in the physical therapy world, was not really being described at that point. So he's like, yeah, I did surgery, and Philippon did a surgery. Yeah. And he's like, I'm doing amazingly well. And I had it was so painful. Like for me, just the thought that and I mean, to my credit, no one was really talking about, but it just hurt so bad. And and I still have open conversations with this player about that whole path. But I think there is so much to be said with the young clinicians out there about as you move along, you learn from your failures, and because of that, it makes you better. Like one of our mentors, Dr. Levitt here, he always said, at the end of my career will be my best treatment because it's got 70 years of experience built into, my hands or my eyes, whatever it might be. So
yeah, I couldn't agree more.
As we wrap it up, I got one just side question that I've been wanting to ask you. One thing that's really difficult for us to treat is OCD, whether it's elbow, knee, hip, wherever. And it seems like the surgeons don't want to do surgery on it at all. So which tells me that it's not a home run for surgery. A lot of times it's just patients and things like that. Do you have any ideas on those real difficult osteochondritis dissecant cases that?
Yeah, well, I mean, the elbow is a nightmare, right?
I know.
So accessing it, you almost have to retro drill them, and if you're going to do something surgical to them. And so when you think about it, it's you have this beautiful cartilage and you just have this bone island underneath it that is loose. Typically when they hurt, they're loose. But anything we're going to do is likely going to potentially violate that cartilage. And it's just you just don't want to do that.
Right.
But I haven't run, and they're funny. They come in waves. A lot of times you get them and you modify their activities for a little bit, and they do fine. They're good. I have a recently good friends of ours, and I just had to have their son last year and drill his, but he's done great from it. But they're just sort of terrifying cases. They can turn horribly bad. If you're going to have to put a compression screw in one of them, the bone can disintegrate. There aren't a lot of surgeries in orthopedics. Spine. There's some of them where you can really do a lot of damage and make them worse. In the sports world, OCD, that's one of them.
Yeah.
That's one of them. You get it wrong, technically wrong, or you do the wrong thing. It's just rough.
So that's every time you're walking into one of them, you're a little bit cautious.
Your hands are sweaty. I mean, I don't get nervous for almost anything anymore. Surgically, OCD, yep.
You're taking a little extra time. And
yep. Yep, carrying the ACL graft, the auto ACL graft from the prep table back to the patient, that's number one biggest stress. Bleeding around a distal biceps repair, that starts to get your heart rate up. Hamstring used to get my heart rate up, not anymore because I do so many of them. And then OCD would be on that list of just,
Yikes.
Yeah. So there's no good clinical
I'm not overly
pearls
religious, but I make the sign of the cross.
Yeah.
no good clinical pearls on that. I mean, it's kind of a
No, I mean, I think there's, but you picked up on it. I mean, it's your observation that none of the surgeons are rushing in to fix this stuff. What does that tell you?
Yeah, exactly.
right.
Do you think that, like, if we're just extremely patient on that, like, let's take your buddy's son that you're talking about, like, if he just waited 2 years, it'll still.
No, there's certain ones that need to be fixed.
Okay.
Yeah. So you have to. Yeah. I mean, this is a family that did the reasonable 6 weeks off. Did it? He even did. He did it limited weight bearing for several weeks, and then did a very slow progressive course back, and it just wouldn't stabilize and it wouldn't heal.
Right.
But I didn't have to do something crazy compression. I just had to drill a few holes in it and stimulate some healing across the thing, and it did great.
Biologics at all in those cases?
For sure, if you could, I don't know exactly how you distribute them yet. I mean, I would say the ones that you have to actually, sometimes you have to actually hinge them up and kind of get some basically calcified bone or whatever off the backside of the lesion, then put it back down and then put compression screws in it. I mean, flooding that thing with stem cells would never be a bad idea.
Yeah.
Maybe not necessary, but not a bad idea.
Maybe that would be a time that you would do it in surgery, or would you still probably refer out for that?
No, I would probably do it in surgery. I would in surgery. I'd actually try to inject it in the backside of it too. But the one beauty of bone is if it goes smoothly. I mean, bone heals the bone amazingly well. Right? It loves to heal together.
Right.
So the thing is, you're looking at this piece and you're like, okay, it's going to be unstable. The knee specifically, it's pretty large. I got to hinge this thing. I got to prepare the backside, put it back down, hope it fits like a puzzle, then put the compression screws in. There's just so many stages for it to go fucking wrong. Like you go to hinge it and it breaks off and it's floating around the knee and you're like, oh shit balls, what am I gonna do now? So it's just so many things can go awry.
I did have one question. Is there any case right now that you're doing an open hip surgery, or are you all arthroscopic?
Oh yeah. It's funny you asked that. So glute stuff. So this isn't so much as the younger athlete, but this is more of our older athletes. But the glute medius tears, trochanteric stuff, greater trochanteric stuff. So I used to teach courses through Arthrex and other ANA and stuff on how to do that procedure endoscopically. So how to put the anchors in and put the sutures in. But then I did a sort of head-to-head comparison in my own practice and did mini opens, and my mini opens just did so much better. So I fixed the glute meds and trochanteric stuff through a mini open. And the hamstrings. Some guys are doing endoscopic hamstring repairs. It's such a cosmetic issue making that incision there, and it's just a hard space to be, and the sciatic nerve is kind of important for your function of your leg. So,
that's when you don't want to mess up.
Yeah, you don't want to be sitting down there with your camera and your metal spikes going, where am I? Is that the hamstring? Oh God, that's the sciatic nerve. So guys do it. I mean, there's a lot of great surgeons, but I prefer to just make a little 4 centimeter incision, get down there that way.
Cool, nice,
Love it, man.
What a great talk. Appreciate your friendship as always and your work, and we'll cheers again. We'll meet you back here in a year.
Thanks for the buzz. Appreciate it, guys.
If you're in the Midwest, this is your guy, David King.
Yep, absolutely. So thanks again for your expertise and for educating us. And I guess we're going to get back to the course, Brett.
Yep.
All right, guys. Have a great day, and good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it. Subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.